Well,
I'm going
John,
to
I
go
just
ahead.
want to thank you for giving me the opportunity also to share with you all. John has worked with me here at the Wellness Center throughout the pandemic, and he's been in the trenches with all of us. So thank you, John.
Yeah, no, thank you. And I've officially started the recording for today's session. So for anyone that's joining late or has to drop off early, we will have the full recording available. And then for those of you that are looking to claim wellness credit for this particular activity, we will send out a very brief post test tomorrow morning. And really the test is really just a way to take attendance. It's not meant to be anything that you have to fret about. And of course it's open book, but that's what we use in terms of attendance tracking. So as I said, again, welcome back to Diabetes University. Today, we're going to, talk a lot about COVID-19 for the diabetes community. We're going to look at some of the latest trends about COVID-19 and diabetes care, but also give you some more specific recommendations on how to manage COVID-19 if you have diabetes, as well as the role vaccinations will play in persons with diabetes, and also how overall blood sugar control seems to really impact overall outcomes with a lot of diseases, not just COVID-19, but some of the other things that we might find as well. So Dr. McIntosh, one of the first questions I had, and again, if you have any other questions that you'd like to type into the chat, we can get to those towards the end. But one of the first questions I had is, do people with diabetes, do they need to be considered in that group that gets that booster shot?
Well, I tell you, it's sort of interesting. The terminology can actually be a little bit confusing. So I just want to clarify third dose versus booster shot. Third dose, the FDA and CDC have recommended, as many of you know, for those people who are immunosuppressed to get a third dose. What does that mean? Those individuals, for example, who've had cancer, organ transplant, cancer that's being treated, organ transplant, stem cells, some type of immune deficiency, perhaps AIDS or untreated HIV, they may not have as a robust immune response to the initial two vaccines that we received, for example, Moderna or Pfizer. Of course, there's AstraZeneca, but we have not many of us have received that vaccine. So therefore, the level of immune response in those individuals who are immunosuppressed has not been as high. So therefore, there is this recommendation of a third dose. Now, a booster dose is for all of those who've actually received the vaccine. And then after a period of time, which is being determined by the research available, probably somewhere between 5-6 months and 8 months, they are to get another shot, which is essentially the same dose of the same vaccine, it sounds like. And that is going to, so to speak, boost our immunity to that level which we originally had. And it may even potentially be a little more as well. So it's an extra protective factor. Now, the studies, a lot of these studies are coming out of Israel, and it seems like it works. The booster does work. It actually, a study that came out, I believe, in the New England Journal of Medicine in the past week shows that it decreased illness, meaning those people who got COVID, by 11 times, and actually by 20 times decreased severe illness, meaning though that which went to the hospital. It's really going to be interesting. I think there's an FDA meeting tomorrow. They're looking at the Pfizer data. They're looking at the studies that have been done, and potentially there will be a recommendation very soon, meaning some have even said on September 20th that booster may be recommended, especially for those like in healthcare or have a higher risk greater than 65. I think, John,
Right.
you're on mute.
Yeah, thank you. So basically, long story short, is really this initial wave of supplemental doses is targeting the immunocompromised, and the people with diabetes don't necessarily fall into that category, correct?
That's right.
Awesome.
Third dose, immunocompromised, diabetes. Those of us who've already had the vaccine will get a booster probably sometime here in the very near future.
Okay, thank you. So another question I've heard and have been asked is in terms of, does having diabetes, whether it's type 1 or type 2 diabetes, make that antibody response to the vaccine any less effective, or does it change its effectiveness, or is it totally unrelated?
Well, the short answer is probably not. Now, we don't have, obviously, we are learning many things from the research that's being accomplished over the past year and a half. But it looks like that the immune response is essentially just as good as anyone else in the population. And one of the conclusions or caveat is that if the immune response was not as good, or at least the data was showing that it was not as robust in those patients with diabetes, they would have recommended a third dose for those with diabetes, and they have not recommended. So the immunosuppressed diabetes is not in that list.
All right, well, that's good. That's great to hear. Thank you. Now, another very popular question, this would be maybe beyond just persons with diabetes, and this is something that you can speak to with your frontline experience. So we hear much about this Delta variant, of course. Are there specific warning signs that somebody should be watching out for in terms of some of the hallmark symptoms of COVID-19 as it relates to the Delta variant?
Well, number one, as far as the signs and symptoms of the Delta variant, it has not really been that different. Now, in my own personal experience, it seems like sometimes the Delta variant has showed more GI symptoms. I've seen a little bit of that in the literature, but really the symptoms are basically the same: the fatigue, muscle aches, headaches, upper respiratory symptoms, loss of taste or smell, sore throat, congestion, and that type of thing. Pretty much the same that we saw in the initial variant. But important also to recognize, though, that if you've been vaccinated, that it may just be a common cold experience, the cough, maybe a low-grade fever, headache. Now, the only real difference is the loss of taste or smell may be there as well. Why is that so important? Well, if you've been vaccinated and you're at home and you have these mild symptoms, at the beginning of the infection, this second infection, you can potentially spread it to others. That means the number of viruses floating around in your upper respiratory tract are basically the same as someone who's not been vaccinated. However, your immune system has already been revved up, ready to attack it. So you develop minimal symptoms, but there still is the risk that you can spread it to your loved ones, your neighbors, to those who haven't been vaccinated, and likewise your patients. So you need to be potentially tested if you have symptoms.
Excellent. Thank you. Now, the next question I have that comes up, and might actually even be two parts, and it has to do with the monoclonal antibodies. So if I get COVID-19 and I have diabetes, should I be asked to also receive this monoclonal antibody infusion? Can you talk a little bit about that question, but also maybe give a little brief synopsis of what this antibody infusion is all about?
Okay. Well, number one, I think if you do get it, the COVID-19, and you have diabetes, you immediately need to discuss this either with your emergency physician or your primary care doctor. That's remind them, because sometimes it may not be brought up in the conversation. how does it work? Basically, when it's basically a complement to the vaccine. It doesn't say, well, if I'm going to get COVID, then I'm going to get the Regeneron Cove monoclonal antibody, and I don't need to get the vaccine. No, it doesn't. It's basically a complement to the vaccine. How does it work? When you have a vaccine, for example, your body produces these antibodies, which is basically artillery. You can think of it that way, which our immune system essentially shoots and kills the vaccine, or destroys not the vaccine, but destroys the virus. So therefore, when you have your onset of symptoms very early in the illness, we give this, basically it's a combination of two antibodies which immediately attacks the virus, or COVID-19, which is in our upper respiratory tract, and significantly reduces the severity of disease. It is an investigational drug, meaning the FDA has approved it under the Emergency Use Act. So there still are studies going on, but I do know that I have administered it in the emergency department. If I had a loved one who had diabetes and they developed COVID, yes, I would recommend, based on the limited data that we have at this time as an investigational drug, that they would receive the antibody.
Now, would that recommendation change at all, or the urgency behind that recommendation change if that person was vaccinated versus unvaccinated and they got COVID-19?
Well, if they're in my emergency department and they are having significant symptoms, that type of thing, yes, I would go ahead and recommend it.
Okay. All right.
Because by the time we find out that you've got more severe disease or moderate severe disease for some reason, then it may be not a useful intervention. However, this is going to be a significant discussion that you're going to need to have with your primary care doctor, or the doctor who's taking care of you at that time.
Gotcha. All right. Thank you. The next question has to do with the chances of contracting COVID-19. So are people with diabetes more likely to get COVID-19?
No, it looks like that, as far as likelihood to get or acquire the virus, no. If I'm sitting next to you or a friend or anyone, I think we all have essentially the same chance of picking up the virus. However, it's the complications that we're specifically talking about. When you have diabetes, you have a higher risk of the complications associated with diabetes.
I got you. Okay. Yeah. So that actually leads right into that next question there. So people with diabetes, they do have a higher chance of serious complications. Is it because of maybe some of the comorbidities, or is it influenced by blood sugar control? Or what is the mechanism that we're seeing that leads to these more serious complications in this group?
Yeah. I think what happens when you have, for example, diabetes, number one, a lot of the people who have diabetes do, just like you mentioned there, have other comorbidities. For example, they may have heart disease, or they potentially just may be older. So in that situation, definitely have a higher chance of potentially, having the serious complications. And other important things, diabetes, sort of the way I think about it, when your sugar is elevated, I think a good illustration is it sticks to everything. For example, if I drop sugar on the floor, I like to use this illustration, and the floor is wet, it sure becomes sticky. And when you have a higher level of glucose in your body, it sticks to everything. And, it sticks to your eyes. That's why you have to follow, your eye test. It can stick to your kidneys and you get kidney problems, or it can stick to your nerves and you get peripheral neuropathies. But also, I think it probably sticks to your immune suppressor cells. And so therefore they don't function as well. And so therefore you have a higher chance of developing serious complications. At least that's sort of the putting my medical knowledge in layman explanation. That's how I put it together.
Yeah, that makes sense. And we have seen in some of the, very early research that came out, individuals who are entering the hospital and had hyperglycemia tend to have much higher rates of serious complications from COVID-19 for whatever the reason was. So again, getting back to that, hallmark recommendation, when we look at all the different ways to approach diabetes care, it's all about trying to find out which approach is going to help you achieve your near normal blood glucose ranges as often as practically possible. Whether medication, diet, exercise, all that's going to be a very important part. Now, the other thing that we're seeing in the literature, and again, this isn't just localized to Duval County, but worldwide, and we're seeing an increase in people being diagnosed with diabetes after developing COVID-19. Why are we seeing that? Any thoughts on that?
Well, just thinking about it, I basically think there may be three scenarios. Number one, they may have had diabetes and they just did not know it before. For example, they get sick, they go to the hospital, they are managed. Obviously, when you're being managed, we're going to be doing testing. For example, we're going to be looking at your electrolytes and that type of thing. And we may catch at that time that your glucose level is high. Number two, you may have pre-diabetes, meaning you haven't been diagnosed with diabetes, but you may have a propensity to developing diabetes. And then when you get the coronavirus or COVID-19, that causes increased inflammation. And we know that when you get increased inflammation, that we may likewise develop increased insulin resistance. So therefore, it unmasks diabetes in those patients. Another thing, when we are treating COVID-19 and you have significant disease where you need to be admitted to the hospital, I'm going to recommend that you receive a steroid. And we do know when you receive steroids that it increases your glucose level, and that likewise will unmask diabetes. And then another thing, when you're infected with anything, be it the flu or just a common cold, for example, it does stress your immune system. Any type of stress on the immune system can likewise increase that concept of insulin resistance. And what is insulin resistance? That just means you need more insulin in order to keep your sugar level down. And so that's when, like, even in type 1, type 2 diabetes, you start using, medications, be it insulin or metformin or that type of thing, to control your sugar level.
Well, thank you. So the one more question I had, and again, we'll open it up to anyone else that has some questions too. And this one, drilling down more to similar questions that we've asked, but just basically comparing type 1 and type 2 diabetes. Is there any difference in terms of risk and complications across the type of diabetes, or is it pretty much the same?
Well, I think you know as well as I do that each individual responds to illness differently. We all have our own genetic propensity. And that's where in the future, this whole concept of personalized medicine is going to be so important. But we've already established the fact that, complications rates are higher in those individuals who have diabetes. Type 2 diabetes versus type 1 diabetes, I would, it looks like the comorbidities that you have with it, meaning age, obesity, heart disease, hypertension, congestive heart failure, renal disease, the more comorbidities that you have, the higher risk, despite having type 1 or type 2 diabetes. There are some suggestions. I mean, we know that people who have type 1 diabetes, basically have no insulin, so they can more easily slip into diabetic ketoacidosis, which can be quite dangerous if not treated appropriately, and you can develop complications of sepsis, which is severe infection. So yes, type 1 diabetes, or even with pregnancy and gestational diabetes, it looks like there may be somewhat of a increased propensity to complications. But I think that the real issue is the comorbidities, but more research needs to be done on it.
Yeah, that makes sense. I mean, if we're dealing with one diagnosis of type 2 diabetes, along with some of the comorbidities, it stands to reason there could be some more complications. So Dr. McIntosh, thank you for answering those questions. I do want to give a chance for people, if you have any other questions now, type them into the chat. So as before with previous sessions, and I mentioned from the outset, we'll send out just a real brief post test to help you get credit towards the wellness credit. So we're going to continue these programs through the month of November. So Diabetes University is basically running year round. We won't have a session per se in December, but next month in October, we're going to talk about mindfulness-based stress reduction. And this is a very specialized technique that can help you kind of, not eliminate the stress, but more effectively manage it. So that's going to be a very good session that Nick Tennant is going to lead in October. And then in November, we're going to talk a little bit more with some of our mental health counselors here at the Champ Center to talk about some of the mental health issues that face persons with diabetes, and what to be aware of and what type of resources we have to help you. So again, a good talk to kind of round out the entire calendar there. So question there in the chat, Dr. McIntosh, is it a guaranteed diagnosis if someone that has insulin resistance get type 2 diabetes? You want to answer that?
Yeah, I'd love to answer, but hey, you can probably chime in as well. But being in the wellness department, lifestyle change is so profoundly important. We're talking about inflammation, and how do you deal with inflammation? It's really about lifestyle change. So I really think nutrition, as John has so well clarified in the past, is extremely important. Sort of the concept of an anti-inflammatory diet. I'm just sort of throwing that sort of big term out there. But the importance of being very careful about the food that you eat, and reducing perhaps, the so-called food that causes hyperglycemia is extremely important, or have a high glycemic index, which just means a lot of sugar in it. Number two, exercise is extremely important because it decreases weight, less fat cells that we have. It potentiates our ability to improve our insulin resistance. Sleep reduces the stress, the cortisol release that we have in our bodies, especially at night. And that likewise decreases inflammation. I could go on and on about the importance, of lifestyle intervention. And I have seen people who have definitely been diagnosed with type 2 diabetes, who engage in a complete lifestyle change, and they're able to get off medications and stay off medications.
Yeah, so short answer there, it is not guaranteed that that person would be diagnosed with type 2 diabetes. So we had done a diabetes prevention program here several years ago, and the two indicators that we really measure to kind of minimize that progression. So individuals with insulin resistance / pre-diabetes, preventing them from advancing to a full diagnosis, is that if they were able to get 150 minutes of moderate intensity activity each week, so that's activity that kind of makes you a little bit out of breath, not too vigorous, but again, where it feels like you did some work. So 150 minutes over an entire week, and at least 5% weight loss. So 5%, that's not a huge number. So if you're 200 pounds, that's a 10-pound weight loss. So those two factors together really went a long way at helping individuals avoid the diagnosis of type 2 diabetes. So it is preventable. Lifestyle plays a big role. I know it can be a lot of changes to consider, but if we can get people moving and just get a small amount of weight off, that can go a long way at helping avoid the diagnosis. So yes, thank you. Yes, some hope, and hope is all we need, right? That's a very important thing.
Absolutely.
Faith, hope, and love. So great question, Carly. Anyone else have any questions? Go ahead and type them in the chat while we have Dr. McIntosh here for a little bit. As I said before, we'll send out the link to the recording and the lecture notes here, as well as information about the post-test credit. And then next month, we'll talk about mindfulness-based stress reduction. Dr. McIntosh, any parting words?
Well, I just want to, maybe two things. Number one, I do have a lot of people ask me, I've already had COVID. Do I need to get the vaccine? And short answer there is yes, you do. And the data is likewise showing that you're more likely to get COVID if you've not had the vaccine versus for example, if you've had COVID, you get the vaccine, or you've just had COVID but did not get the vaccine, then you're more likely to get COVID. So obviously you want to get the vaccine. And then number two, there's going to be this question, especially we're looking at the flu season. Can I get my flu vaccine and then go ahead and get my booster if it's made available? Do I have to wait the 14 days? Recommendations from what I've seen is that no, you're not going to have to wait that 14 days. So if you have, you get the flu vaccine, for example, tomorrow, and then the booster rolls out, next week, do I have to wait the whole 14 days? No, but that's the recommendation of the CDC. But we can all keep our eyes and ears open for any changes from that standpoint.
All right. Well, thank you very much again. Thank you, Dr. McIntosh, for taking time out of your schedule to share some of your wisdom. And again, thank you to everyone else for tuning in. And we look forward to seeing everyone again next month. And if you have any questions the interim as far as diabetes self-management or questions about any other programs, we are relaunching our In Control Diabetes program at the end of the month. So if you're looking for a little bit more pointed information on diabetes care, this is a program we've done for several years. So if you've never heard of it, this might be a good time to sign up. All the details are available on our employee wellness website. So for myself and for Dr. McIntosh, everybody, please have a good rest of the day, and we'll see you around very soon.
Take care. Thank you.
Thanks, Dr. Mac.